we are about to start our monthly clinical meeting, which is for our junior colleagues, PGTs and junior colleagues. It is a competitive session. The rules are you have a presentation time of 8 minutes, and there will be questions by the judges for which the scores will be given. And from audience, for discussion, we invite suggestions and questions also, but that scores will not be given on that questions which are from audience. And we have with us our judges, Dr. Subhajit Banerjee, our past president, Dr. Utpal Jana, our vice president, and Dr. Bidhan Roy, our editor. And so without any delay, we are starting this today's clinical meeting. Also, it is good that it is very good for us that lot of papers are submitted for this clinical meeting. We could not accommodate all of them in this meeting, so we have rescheduled those who have could not participate in today's meeting. The next meeting will be on 9th of November, Thursday, at same venue at same time. So we will start our program. There will be warning bell 30 seconds before the time, and there will be 2 bells when your time is finished. We have a definite score sheets, and scores are given on the basis of the time management, the presentation style, and the theme, and the study material. So 9th November, Thursday, next clinical meeting. And so over the judges, we are calling one by one the presenters.
First speaker, Dr. Sabori Ghosh. Case of congenital cholesteatoma and its management.
Just start, okay?
Good afternoon to my respected teachers, seniors and colleagues. I'm Dr. Sabori Ghosh and I'll be presenting a case of congenital cholesteatoma and its management. My patient was a 6-year-old female who presented to the OPD with difficulty to close the right eye and deviation of angle of mouth for 3 months, which was sudden in onset and gradually progressive. And according to her guardian, she had impaired hearing in the right ear for 2 months, which was insidious in onset and gradually progressive. On examination of the ear, bilateral pinna was symmetrical. There was normal preauricular, postauricular and external auditory canal, and there was no 3-point tenderness present in bilateral ears. On otoscopy, there was intact pars tensa and pars flaccida seen in the right ear with a pearly white mass seen behind all 4 quadrants of the pars tensa, and in the left ear, there was intact pars tensa and pars flaccida. On facial nerve examination of the right side, there was no facial asymmetry at rest. There was inability to close the eye at rest, but possible on forceful closure, and deviation of angle of mouth, which was not present at rest, but on clenching of the teeth. There was escape of air on blowing of the cheek, and no wrinkles on the frowning of the right side, and no impaired taste sensation. From this, we can conclude that this is a grade 3 type of lower motor neuron facial paralysis of the right side. Tuning fork test, the Weber's test was lateralized to the right ear. However, serial Rini test and absolute bone conduction test was inconclusive due to the age of the patient. The vestibular function test was normal, and examination of the nose, oral cavity, oropharynx and the neck was normal, and no abnormality was present in the systemic examination. So my provisional diagnosis is a case of congenital cholesteatoma of the right ear with mild conductive hearing loss and grade 3 facial paralysis of the right side of lower motor neuron type. Management in preoperative steps, we examined under the microscope when we saw white reflex seen behind the intact tympanic membrane of the right side. We did a pure tone audiometry which showed a mild conductive hearing loss with AB gap of 23.33 in the right ear and a type B tympanometry curve. HRCT temporal bone in successive axial cuts, we can see there is intact ossicular chain and there is a white opacity seen in the mastoid cavity. In the coronal cuts in the previous slice, we can see intact ossicular chain network. There is a soft tissue shadow present in the mesotympanum and there is intact horizontal part of the fallopian canal, and in the lower image we can see there is opacity in the mastoid air cells and there is vertical segment of the fallopian canal is intact. On steps of the operation, where the patient was positioned under general anesthesia and after giving post-auricular wild incision, we elevated the tympanomeatal flap which was thin and there was glue surrounding the entire sac region. We encountered a postic grade 2 congenital cholesteatoma sac which was present in all the 4 quadrants and anteriorly only the handle of malleus was visible. We did a partial canaloplasty in order to calibrate the canal and expose the extent of the sac, whether to see if there was any connection with the ossicular network and so that we can remove the cholesteatoma sac in toto or not. After determining that, we removed the sac in toto, and after removing the sac, we can see the middle ear mucosa which was healthy and there was no presence of any epithelial cells in the middle ear cavity and the mobility of the ossicles was intact and there was no erosion. Round window reflex was also present. The adductus and the mastoid amptum had glue which was suctioned out. This is the 0.9 centimeter of the congenital cholesteatoma sac which was present and it was confirmed by histopathological analysis. This is the post-operative findings 3 months after, which shows a healed tympanic membrane and complete resolution of the facial paresis as well as an improved hearing from 38 to 28 PTA. So congenital cholesteatoma is defined as the pearly white mass seen behind an intact tympanic membrane with the normal pars flaccida and normal pars tensa, with no history of otorrhea, perforation and no previous otological procedure. However, previous bouts of otitis media and effusion are included in the criteria. Incidence, it forms about 2 to 5% of all the cholesteatoma, which forms 12% of 100,000 children, and average age of diagnosis is from 5 to 6 years. Location intradurally, it is most commonly found in the cerebropontal angle, and in the extradurally, it is anterior superior quadrant followed by the posterior superior quadrant of the tympanic cavity. Presentation, it mostly presents as a pearly white mass in the middle ear behind the intact tympanic membrane. It may be asymptomatic. It is conductive hearing loss and chronic otitis media in 50% of the cases. If it presents with facial paralysis, we have to exclude the malignancies, metastasis and facial neuromas, and if it extends towards the labyrinth, then it forms congenital sensorineural hearing loss as well as vertigo. It spreads most commonly posteriorly along the medial surface of the ossicles, in the IS joint, in the facial recess, in the sinus tympani, and lastly into the mastoid air cells. Inferiorly, it can also proceed towards the hypotympanum, but it spares the stapes footplace and the otic capsule. Most common accepted theory of the pathophysiology of the congenital cholesteatoma is the epithelial rest, which are aiding in the development of the middle ear and the tympanic cavity. They are initially goes rapid proliferation but resorption around 33 weeks of gestation. However, if there is chronic inflammation present, it may lead to incomplete resorption of the sac, which may form a congenital cholesteatoma. Other theories include in theory of invagination, which there is an inflammation and injury present in the neck of the malleus, which leads to invagination of the epithelium into the middle ear cavity, and it may cause a congenital cholesteatoma formation. There is also a theory of implantation, in where there may be a small perforation in the tympanic membrane, which may cause implantation of the epithelium into the middle ear cavity and formation of congenital cholesteatoma. And there may be metaplasia of the squamous epithelium lining the middle ear cavity, which may form a congenital cholesteatoma. Histology, it is indistinguishable from the acquired type by histology, and therefore only a clinical picture is important to determine the difference between the two. On HRCT, we see a hypodense expansional lesion which is round to oval in nature and with well-defined margins which do not enhance on contrast. Staging most commonly used is Potstick and the Nelson staging. According to my case, it is a stage 2 Potstick staging and a type 1 Nelson staging with the least incident of the two. Recently, there is a Japan Otological Society staging system for congenital cholesteatoma. It differentiates all the types on the location of the congenital cholesteatoma as a middle ear, mastoid cavity, as well as the hidden areas such as sinus tympani and extradurally. Surgical methods. Earlier, the main surgery was a canal valve and mastoidectomy for complete removal of the disease, optimal hearing procedure, and the prevention of the recurrence in children mostly. But now, according to literature, Bennett et al., as well as other sources, majority of the isolated anterior mesotympanic lesions can be adequately approached through a standard tympanoplasty. So we can avoid all the complications which are associated with the canal down mastoidectomy, such as repeated syringing as well as removal of the disease. The limited anterior congenital cholesteatoma has extremely low rate of recurrence, and therefore only a single step is efficient. In my conclusion, my case presented with a complication of facial nerve paralysis and a congenital cholesteatoma here, which we managed by removal of sac by anterior tympanometry, and post-operative findings was adequate, complete resolution of the facial paralysis, improved hearing, and no recurrence of the disease. These are my references, and I took due permission from the patient's guardian to show the pictures. Thank you.
Thank you, Dr. Ghosh. It was a nice one. Now, just coming to a question, just think that there is an extensive, disease in the ossicles. All the ossicles are involved in a type 3 type of master. What will be your line of, treatment, surgery? How can you reconstruct the ossicles like that in a child?
So first we will go for a canal valve and mastoidectomy, then removal of the ossicles, and if we need to repair the hearing mechanism, we can go for a PORP or a TORP or type 3 tympanoplasty using cartilage as well.
In the same sitting, or just you will wait for 1 year or like that? Do you
Sir,
prefer to do it in the same sitting?
Usually we follow the disease. So in this case, we did a aticotomy and the disease was removed. However, if this includes the ossicles, then we can go in the same sitting as a cortical mastoidectomy. But in case if there is a recurrence of the disease, we need to take a second look at the examination. We can take after 6 months.
How can you assess that the ossicles are still damaged like that? It is not well constructed. How can you assess? Is there any MRI or like that you have to do?
Sir, we can do a CT scan as I did in my case, and if we need a second look, we can do a differentiated MRI, fat contrast MRI, so we can see the differentiation between whether there is a congenital cholesteatoma sac present or not, and if the ossicles are involved or not.
And one thing, just last question. If the posterior canal wall is involved by cholesteatoma, what will be your process? Canal wall down or up? With the posterior canal wall.
Posterior canal wall. Sir, I'll do a canal wall down mastoidectomy.
Yes, okay. Okay. Thank you for the presentations. Just one question. Can you explain the patients developed facial paralysis but without any ossicular necrosis? How will you explain this?
Sir, because of the age of the
Because
patient.
in our experience, usually cholesterol first destroy the ossicles, then the facial paralysis. But in this case, the patient developed facial paralysis,
Yes.
but without any destruction of the
Yes.
ossicular chain.
So due to
What is
the
the main reason behind it?
Sir,
What
we
your-
can postulate because of the age of the patient, there is 77% of the cases in this age present as a dehiscent tympanic segment of the facial canal. So it may, if there is any kind of otitis media, then there will be inflammation of the, also there can be toxins produced by the
Yes, you are
cholesteatoma.
right. Okay,
Ha, sir.
So, what is your message to the audience regarding this case?
Sir, my message to the
It is
audience
a very
is,
common case. We used to encounter this type of cases.
yes.
What is speciality or what is the special in your presentation?
The speciality is basically the management, the surgical operator. Mainly we used to do a canal wall and mastoidectomy in any case of cholesteatoma. But here we saw only an anterior tympanotomy is enough to remove the entire sac, and there is no recurrence as well after, and we saw the entire middle ear cavity by a pediatric endoscope that there is no epithelial rest cells present in the middle ear mucosa as well. So that is one step is enough for, we don't need to go for an aggressive surgical procedure because that will invite complications as regular follow-up and syringing of the ear and etc.
Then when one stage is enough and when it is not?
Sir, we
when
will.
one stage is enough and when it is not?
Sir, if the congenital cholesteatoma sac is present in the anterior mesotympanum and it is not involving the ossicles, we can remove the sac in toto and then we don't need to go for a aggressive procedure. But if the congenital cholesteatoma is including the ossicles, there is ossicular erosion, if it reaches the facial canal, then we go for an aggressive procedure.
Okay, thank you.
Any questions or suggestions or comments from the audience? Okay, I request Dr. Shamal Ghosh sir to hand over the certificate to Dr. Shabori Ghosh. Next, Dr. Nisha. Her topic is bone bridge implant, a newer way of hearing rehabilitation.
Good afternoon, respected faculty, senior residents, and my dear friends. Today I am going to give a presentation on bone bridge implant. The aim of my presentation is to compare bone conduction implants with or without transcutaneous abutment, candidacy for bone conduction implant, surgical planning for bone bridge, surgical steps, and the outcome. I am not covering these topics. So, bone conduction implant is of two types, active and passive. In active device, it directly stimulates the bone. In passive, it transmits the vibration via the skin. In active, we can have transcutaneous abutment. So, bone anchored hearing aid is a type in which there is the audio processor is attached outside, and with a transcutaneous abutment, it transmits the vibration to a titanium implant which is osteo-integrated. The other type without transcutaneous abutment is a active bone conduction implant which is totally implanted under the skin. The skin layer is intact and the audio processor lies outside externally worn, and through a magnetic coupling the signal is transmitted. This is active because the transducer here directly transmits the vibrations to the bone. The working principle in bone conduction implant is that the externally worn audio processor, it has microphones. The sound waves are received by the microphones of the audio processor and it is then converted into electrical signals. These electrical signal is then transmitted to the implant which is placed inside the intact skin. This signal is then transmitted to the floating mass transducer, which then converts the electrical energy into vibrations. These vibrations are then directly transmitted to the inner skull and to the inner ear, and this the audiological stimulus is then transmitted similarly as a physiological bone conduction. It bypasses the external and middle ear completely. The dimension of the bone conduction implant is about 6 centimeter and it contains of attachment magnet with a receiver coil with a positioning aid and the transition which helps in the coil moving the coil laterally above and downward 90 degree. It also consists of a bone conduction floating mass transducer which is placed inside the bone, and the depth of the drilling is required is 4.5 millimeters and it has a self-fixating screws. Candidacy includes patients of 5 years or older because the thickness required for drilling is minimal 5 millimeters. Conductive hearing loss and mixed hearing loss, where the bone conduction should be better than 45 decibel. In single-sided deafness, the contralateral ear, the bone conduction threshold should be within 20 decibel. Also, the congenital or acquired middle and external ear diseases. Also, the patients who are not benefited with conventional hearing aids and when they are given bone conduction trial, they are getting benefit from them, and patients should have adequate motivation and realistic expectation. These patients can be considered for bone conduction implant. I am representing two of the cases which underwent bone conduction implant in our institute. Our first case is a 29-year-old female who presented to us with complaints of difficulty in driving two-wheeler in traffic. And on further interrogation, she told that she had this complaint since childhood. On clinical and audiological examination, external ear, pinna and EAC tympanic membrane was all normal. Uh, Tuning fork test revealed sensory neural hearing loss profound on the right side. Pure tone audiometry was done and it also confirmed the right-sided profound hearing sensory neural hearing loss. Left side was normal. On aiding on aided audiometry, the responses were not beneficial on higher frequencies. Her CT scan and MRI was done, and she had dysplasia of vestibule and semicircular canals, but her cochlea and nerve complexes were normal, same revealed in MRI, and she was diagnosed as unilateral congenital profound sensory neural hearing loss. Our second case is a 55-year-old male who presented to us with hearing loss on the left side for 8 years, and that developed after an acute episode of viral fever. History was suggestive of likely parotitis, and his clinical examination and TFT revealed profound hearing loss on the left side, profound sensory neural hearing loss on the left side. Aided audiometry was not beneficial. It was lower in the speech banana. His HRCT and MRI was normal, and these two patients were considered for bone conduction implant. For bone conduction implant, the placement of the transducer can be retrosigmoid, sinodural angle, that is transmastoid, or the middle fossa region. An autoplan was generated, which is an artificial intelligence based autoplan, and it depending on the inputs given by us, the radiological inputs given by us, it gives a plan. So for both our patient, the autoplan suggested us a retrosigmoid approach. But this was our radiological evaluation, and we found the sinodural approach to be a better option. And for both the patients, we went ahead with the sinodural approach. These are the surgical steps. Marking with a footplate sizer was done. Local infiltration with 1:1 lakh ADR with NS was given in the post-auricular region. Skin flap thickness, which should be minimally 5 mm, it was measured during a needle and it was found to be 4 mm. Post-auricular skin incision was given. The skin incision should be at least 2 cm from the posterior superiorly placed coil, so that when the implant is there, it does not, when the external auditory processor is placed, it does not touch the pinna. Soft tissue dissection was done, and periosteal pocket for the receiver coil was made, and it was checked using FP sizer. Coil placement was checked. Skin flap thickness was again measured using a skin flap gauge of 7 mm and found to be less than that. Bone bed for bone conduction floating mass transducer was created at the sinodural angle according to our radiological planning. Drilling depth was confirmed. Flat contact surface of FP sizer was confirmed using a needle. BCI was planned, and again the flat surface was confirmed, and self drilling screw were placed, and fixation was also confirmed. This was the wound closure, and after post-op day 7, the status of the wound. And this is at the first patient who underwent bone conduction implant, and she underwent surgery for the right ear, and after closing her left ear, she was able to answer most of her questions. This was a milestone surgery of Kolkata in Armed Forces. This is our surgical team.
Thank you, Dr. Nisha.
Thank you so much.
It's a nice presentation. Just consider a situation where both of the ears have unequal deafness.
Yes, sir.
Which side you will select for implant?
Sir?
Which side you will prefer? I mean, there is one side is having a less amount of contact deafness, and one side is having more contact
Yes, sir.
deafness.
So we won't be considering in this. If we are considering, we can consider the patient for sensory neural deafness. Then the single-sided deafness. Then the contralateral ear should have normal bone conduction, so that because this is based on the principle of vibration to the inner ear directly. So the other ear should be normal. If both are having sensory neural hearing loss, then we won't be considering this. We'll
If both are having same amount of conductive hearing loss,
conductive.
both here,
Yes, sir.
which side?
Sir, the more conductive hearing loss we'll consider.
Equal.
Equal, sir.
Yeah.
Then, sir, patient's preference, we can go ahead with that.
Okay. And where do you keep the magnet? It is beneath the skin or outside the skin? Just
Sir,
magnet.
Magnet is beneath the skin, sir. The receiver coil has a magnet, and also the audio processor also have a magnet. So they are coupled through the intact skin
The
with
implant is having a magnet attached with.
Yes, sir. I have that photo also. That receiver coil, it has a magnet, so that the audio processor, when worn, it couples with the magnet.
So there is two magnet
Sir.
inside the
Yes,
skin
sir.
also and outside the skin also.
Right, sir.
What are the other indications for doing this type of bone bridge implant?
Sir.
Other indications besides this unilateral sensory hearing loss?
Sir, single-sided deafness, and if a patient has undergone oral atresia, if patient have, or in otosclerosis where the surgery has failed, and if patient has gone blind sac closure with petrosectomy, there we can consider these
Okay.
options.
Just one question actually. What is the maximum level of bone conduction threshold, lower, which can be benefited from this bone bridge implant?
Sir,
In your case, it is 71.
Yes, sir.
Eh? What is the maximum limit?
Sir, sensory neural hearing loss can be profound. If we are considering in conductive or mixed
Yeah,
hearing loss, then
conductive.
the bone conduction should be 45 decibels. Sir.
Maximum up to 45 decibels.
Right, sir.
Just tell me about the maximum permissible thickness of the skin actually,
Sir.
which is covering the implant.
Yes,
it
sir.
should not be too thin, it should not be too thick.
Yes, sir.
What is the maximum permissible thickness?
So it should be less than 7 millimeter. We have that skin gauge of that, and we check that.
Should be less than 7 millimeters.
Yes, sir.
Any comment or suggestions or questions from the audience? अरे आज का क्यों नहीं? Okay. So I request Dr. Ramanand Sinha sir to come and hand over the certificate to Dr. Nisha. Our next speaker is Dr. Akib Ashraf. His topic is Perry-Romberg syndrome.
Good morning, my respected teachers and fellow colleagues. I am Dr. Akib Ashraf. I am here to present a case on Perry-Romberg syndrome. So, since the advent of time, facial aesthetics has been a very important part in human civilization. So much so that few scientists took out time and dug up 200 mummies and then did a study on their facial aesthetics with CT reconstruction. They found out, according to this literature, that 2 out of 200 cases were suffering from Perry-Romberg syndrome. With this much mystery behind it and the presence of disease since ancient times, we move ahead to unravel the mystery. So the patient, 17-year-old female with discharge from bilateral ear, presented to ENT OPD with progressive hearing loss from both ears. She also complained of right side facial atrophy. Further, there was no history of any major surgery. There was a vague history of intra-oral injection, preferably intratympanic, which was given at a tertiary care hospital. No documentation was given by the patient. On clinical examination, it was found out that the patient was having a right side facial atrophy, and it was compared with the previous image, and it was seen that she had a very profound right side decrease in facial aesthetics. Further, we did autoendoscopy of the both ears. Left ear was seen to have a polyp arising from the attic. On probing, it was found that it was non-friable and the tympanic membrane was not visualized, it was firm. In the right side, there were two retraction pockets, one in pars tensa and another in pars flaccida. The pars tensa had a grade 4 retraction and the pars flaccida had a grade 3 retraction. Further radiological investigation like X-ray and CT scan showed that there was a right-sided maxillary sinus atrophy. There were no other significant findings in the radiological investigation. PO2 audiometry revealed that the left ear had a 83.3 decibel hearing loss with an airborne gap of 40 decibel, and the right ear had a 68.3 decibel hearing loss with an airborne gap of 30 decibel. Further, what did we do in this case? We did a modified radical mastectomy to treat the ear disease of the left ear. We sent the patient and advised her for follow-up, and we sent her to PMR OPD, physical medicine outdoor, for facial exercises. And then we have planned a right ear surgery after 6 months. So the patient presented to us. What is the diagnosis? There are a few diagnostic dilemmas in this case. First one is linear scleroderma. It is by far the most important differential in this case because of its overlapping feature with Parry-Romberg syndrome. But linear scleroderma presents with significant sclerosis of the face with a frontoparietal scarring and alopecia and hyperpigmentation, which was absent in our case. Then there is Rasmussen syndrome. Rasmussen syndrome is basically unilateral cortical atrophy of the brain, which manifests as neurological symptoms such as seizure, such as progressive hemiparesis, and decrease in overall cognitive features of the patient. Then there is Barrichelor-Simmons syndrome. Barrichelor-Simmons syndrome is bilateral and it involves mainly the adipose tissue. So basically our case is a diagnosis of exclusion. None of these were found in our patients. So Parry-Romberg syndrome, it was first described by Philip Hilary Parry and Moritz Heinrich Romberg, and it has an incidence of 1:7 lakh, which is very rare, and it's slight female preponderance. Parry-Romberg syndrome basically is characterized by a unilateral atrophy of skin, subcutaneous tissue, cartilage, and even sometimes bones. So it is a very rare disease and should be investigated further. But the pathogenesis here is very scattered and heterogeneous. So there are few hypotheses proposed. One is it can be due to trauma. As seen, there is 24% to 34% of the cases are associated with trauma. It can be iatrogenic during vaginal deliveries or due to dental avulsion. It can be during some accident. Parry-Romberg syndrome is autosomal dominant with incomplete penetrance. It is seen to be associated with autoimmune diseases and incidental diagnosis or finding such as discovery of ANA, anti-nuclear antibodies, anti-centromere antibodies, anti-double-stranded DNA antibodies, and anti-histone antibodies suggest that it has some association with the autoimmune disease as well. Infection, there are a wide range of infections starting from otitic infection to tuberculosis to dental infection to syphilis to rubella, which are seen to be associated with Parry-Romberg syndrome. Tumor such as orbital neuroma, mandibular odontogenic fibroma, hemangioma are seen to be present with Parry-Romberg syndrome. So any of these can be like the trigger a Parry-Romberg syndrome onset. So what are the treatment? Exactly what is done according to literature? There are two steps. Step one is to halt the progress of the disease, and once the disease progress has stopped, after 1 to 2 years gap, we should go for further surgery to improve the aesthetics of the face. In step one, there can be systemic and local therapy. Systemic therapy is corticosteroid methotrexate and can be given in combination or alone. And then there are cyclophosphamide. In few studies, there are penicillin and also antimalarial drugs given. Locally, vitamin D analog, botulinum toxin injection and topical steroids are also given. And then after a gap of 1 to 2 years, we can move ahead with lipofilling, flaps such as superficial temporal flap, anterolateral thigh flap, serratus anterior flap, and autologous flat transplantation. But again, these surgeries fail because due to gravity, the patient reverts back to its previous condition. So what is the take-home message? First of all, in this case, the patient complained of facial atrophy and the infection, otitic infection, and the injection which was given in tertiary care hospital both overlapped. So it can be either of two. Second, due to loss of facial aesthetics, there was severe mental trauma to the patient. So we should always take into account the psychological support. more understanding about the etiology, about the disease process needs to be done. And there, the pathogenesis, as you can see, it is heterogeneous and there are only hypotheses regarding this case. So further studies should be done to ascertain the pathogenesis, to treat the disease, to understand the etiology so that we could further treat the patients with Pyromberg syndrome. These are my references and thank you.
Thank you, Dr. Asraf. This is a nice case. Just only one question. Was there any neurological deficit? I mean, neurological problem in this case?
No, sir. The patient did not have any deviation of mouth, no tongue deviation, or her speech was also normal. There were no other neurological deficit as far as the patient was concerned.
Have you done any MRI? MRI brain?
Yes, sir. We did an MRI, but there were no other neurological findings in the brain.
What are the findings you may expect in case of
Sir, there
neurological
can be,
findings in MRI?
yes, sir.
In MRI,
Sir, in
what
case
you are
of
expecting to get?
MRI, the patient can have a bit of cortical degeneration with area of infarcts.
Okay, this is a very nice presentation.
Thank you, sir.
So why you are thinking this is the underlying cause? That CSM is the underlying cause. Why you are thinking so?
Sir, according to the literatures what we have seen and the history, that there is onset of the infection 2 years ago, and since then only the patient received an injection, and since then only it has started to deteriorate. Now when she has come to our OPD, it is stagnant right now, but it has been starting from that only. So according to the hypothesis, it can be either of the two causes.
Okay.
So, according to you, actually, what is the expected progress of this peri-eruption syndrome?
Sir, Peri-Romberg syndrome basically can progress from 2 years to 20 years. In this case, the patient, the disease process has already stopped. There was no drug given. So now we have to move ahead to improve the facial condition and
But
aesthetics of the
CSM
patient.
was still persistent there.
Yes, sir. The CSM was still persistent. So we'll treat both the ears first so that there is no infection. And then we can send her for facial exercises or further reanimation surgeries.
Very rare case, needs much more exploration actually. So you have gone through the literature before presenting this case.
Yes, sir.
Have you gone through the
Yes.
literature? So what is the actually commonest mode of presentation of this thing?
Sir, most common is sir, progressive atrophy of the face. The patient starts
Progressive
coming.
atrophy of the face. So worldwide, most accepted basic pathology is what?
Sir, it is due to trauma, some kind of trauma. 24 to 34% of people have proposed that it is mainly due to trauma.
Did any literature suggest you about the defect in the cerebral sympathetic chain?
Yes, sir. There was a study which can
That
be due to.
explains all the things. That explains not the autoimmune, not the viral. It's a disorder in fat metabolism actually. From the localized defect in the cerebral sympathetic chain. Maybe due to autoimmunity, maybe due to trauma, maybe due to viral infection or even something else. The worldwide accepted pathophysiology is the localized dysfunctioning or atrophy of the cerebral sympathetic
Cerebral sympathetic
chain actually. So again, you started with 1 in every 200 reconstructed CT
in
were
mummies.
presented with hemifacial hypertrophy.
Atrophy.
So only hemifacial hypertrophy is not the diagnostic criteria of this thing. There should be some other things also. Atrophy of the subcutaneous tissue, fat, everything.
Sir, but it was mentioned in the literature only that they suffered from Peri-Romberg syndrome. I'm just.
Okay, that's good. That's good.
Yes, another one. Have you heard the term flare? Flare in MRI. Flare. FLAIR.
Sir, I didn't.
In MRI scan.
Any comment or suggestions from the audience or questions? Okay. I request Dr. Tapan Hajra sir to come and hand over the certificate to Dr. Akib Ashraf. Now, next speaker is Dr. Srijita Mahapatra. Her topic is impact of sublingual immunotherapy against various unavoidable allergens in cases of allergic rhinitis.
Good afternoon, everyone, respected judges, my seniors, and my colleagues. I'm Dr. Srijita Mahapatra, and today I'm going to give a presentation on the topic Impact of Sublingual Immunotherapy Against Various Unavoidable Allergens in Cases of Allergic Rhinitis. The allergic rhinitis is an inflammatory IgE mediated disease characterized by nasal congestion, rhinorrhea, sneezing, and or nasal itching. The different allergic triggers or the allergens for the allergic rhinitis can be mites, pollens, animal dander, fungi or molds, and food allergens. The most important of them all are the house dust and mites, which are the major causes of the persistent symptoms in persistent rhinitis because they are completely unavoidable. As per the ARIA guidelines also, we can see that they have recommended immunotherapy in persistent allergic rhinitis for the curative intent. As in this case, patients are exposed to the unavoidable allergens throughout the year and symptoms cannot be controlled by pharmacotherapy alone. My objective is to study the impact of sublingual immunotherapy, that is SLIT, against the most common unavoidable allergens. The materials and methods. It was a healthcare facility based observational longitudinal study which was done at an ENT clinic in Kolkata for a duration of 1 year, starting from 10th August 2022 till 9th August 2023. The allergic rhinitis patients who are allergic to the unavoidable allergens and attending the ENT clinic was my study population, and the total sample size was 30 patients who were taken conveniently by simple random sampling methods, and the patients were selected by random number table from the clinic register. The information was collected from every willing patient attending the ENT clinic. The inclusion and the exclusion criteria. The inclusion criteria were patients in the age group of 20 to 40 years who are willingly undergoing treatment and literate and a permanent resident, that is, they can follow up, and the patients who are allergic to the unavoidable allergens. And these were my exclusion criteria. The study tools were a clinic register and patient's treatment card, a relevant skin prick test report, an allergen containing vial box along with the lancet and the measuring scale, a pre-tested and pre-designed semi-structured questionnaire, that is a SNOT-20 score, and the sublingual immunotherapy. These were my study tools. This table shows the results of the allergic skin prick test which was done for 56 allergen in 30 patients. Here you can see that wheat was found to be positive in 12 out of 30 patients, that is 39.96%. The aspergillus fumigatus is found to be positive in 39.96%. The house dust in 46.66%. And the mites are found to be positive in more than 83% of the population. After the skin prick test was done, we selected 6 most common unavoidable allergen from our study population of 30 patients, which were mite D. ferrini, mite D. teroni sinus, mite blomia, house dust, aspergillus fumigatus, and wheat. All the patients who were found to be positive for these allergens were given specific SLIT for 6 months. The SNOT-20 score for each of these patients was taken on day 1 and after 6 months of SLIT. The difference in this SNOT-20 score of day 1 and after 6 months indicates effectiveness of SLIT and clinical improvements in the symptoms of these patients. The sublingual immunotherapy. It is a type of local immunotherapy which induces tolerance against the allergen. In SLIT, vaccines were started at a lower dose and gradually increased until a therapeutic dose was reached. The drops were administered by the patient at home after receiving first dose at the clinic, as you can see in the image. The drops were to be taken below the tongue and patients were advised to wait for a few minutes and then swallow the drop. The SNOT-20 score. The possible range of the SNOT-20 score is from 0 to 5, which consists of 20 questions pertaining to some nasal symptoms, oral symptoms, sleep symptoms, and some psychological or behavioral symptoms. As each of these 20 questions is assigned a score from 0 to 5, so the maximum possible score becomes 100. This is the SNOT-20 score. This table shows the results of the SNOT-20 score on day 1 and after 6 months of SLIT and the difference between them for all the 26 patients in case of mite D. ferrini. Here you can see that for patient number 1, the SNOT 20 score on day 1 was 65, which was reduced to 12 after 6 months of slit, and the difference becomes 53. In the same way, this SNOT 20 score was calculated for all the 6 allergens. This table shows the results for the mite D. teroni sinus. This one is for the mite blomia. This is for the house dust. The next one is for the aspergillus fumigatus, and the last one is for wheat. After the collection of data, we calculated the t-value for statistical analysis. The mean of the differences in the SNOT 20 score on day 1 and after 6 months was taken for calculation of t-value. The mean of the differences in the SNOT 20 score for mite D. ferrini, mite D. teroni sinus, mite blomia, house dust, aspergillus fumigatus and wheat are 55.5, 56.64, 56.56, 51.41, 32.41 and 28.08 respectively. So the calculated t-value was found to be more than the tabulated t-value for all the 6 allergens. So we can say that at 5% level of significance, the difference is highly significant, which implies that slit was effective against all the 6 allergens. The next we calculated the Z value, that is the standard Romer variant, which was calculated by taking mite D. ferrini as the variable one, as the mean of the differences for mite D. ferrini amongst all the mites was least. And then it was compared to house dust, the aspergillus fumigatus and wheat, which were taken as variable 2. The Z value was calculated for aspergillus fumigatus and wheat, which were 3.69, 18.33, 28.2 respectively, which was found to be more than 1.96. Therefore, we can say that the SNOT 20 score for mites is more significant than the SNOT 20 score for house dust, the aspergillus fumigatus and wheat. So we can discuss that after 6 months, the slit was reduced in case of all the 6 allergens, and this means that slit was effective against all the allergens by clinically improving the symptoms of the allergic rhinitis patients. The difference in SNOT 20 score was observed to be more in case of mites, house dust and aspergillus fumigatus as compared to wheat. Therefore, we can conclude that slit is most effective against the unavoidable allergens like mites, house dust and fungus like aspergillus, and relatively less effective against food allergens like wheat. If the patient is found to be allergic to the multiple allergens, it is better to suggest immunotherapy for completely unavoidable allergens like mite, house dust than the relatively unavoidable food allergens like wheat. These are few of my references. Thank you so much.
Thank you, Srijita. It was a good thing, good presentation. How do you do a skin prick test?
So, to perform a skin prick test, we have to first ask the patient to stop any anti-allergic that the patient is taking 5 days before the test. And then on the day of the test, we give stamps on the inner aspect of the forearm, and the boxes are numbered accordingly to the vials that are to be used. Then with the help of a lancet, we introduce a small amount of allergen by skin prick and wait for a few minutes for the allergic reaction, that is the wheal. After 15 minutes, we measure the size of the wheal, and if it is found to be more than 3 mm, then it is found to be a positive wheal reaction, and then accordingly we can prepare the result of the allergic skin prick test.
In which condition you can't do the skin prick test?
Sir, pardon?
In which conditions you cannot do a skin prick test?
The conditions in which we cannot do skin prick tests are the patients who have severe symptoms, and we cannot advise them to stop the pharmacotherapy before the skin prick test, or the patients who have dermatographism and patients who are having severe urticaria.
What will be your solution for them?
Sir, if skin prick test cannot be done, then we can suggest an alternative test, which is a blood test for the estimation of allergen specific IgE.
Just one problem. In a situation where you find 10 different allergens for a particular patient, how will you do the slit?
Okay,
Just a
sir.
patient came to you with 10 different types of allergen. Okay.
Sir, first we have to keep in mind that the slit can only be given twice a week. That is, only 3 sets of slit can be given. So, first we have to divide these allergens. Like in your case, the patient is found to be allergic to 10 allergen. So, we can divide the allergens into avoidable and unavoidable. And we can ask the patient to avoid the avoidable allergens. amongst the unavoidable allergens, as different allergens cannot be mixed in the same bottle, so we have to find the allergens which are causing more reactions or more severe symptoms. That can be identified by looking at the size of the wheel. The allergens that are causing a greater wheel size are more serious, and patients are more allergic to those allergens. So in this way we can identify three most important allergens against which we can give the slit.
Just one question. What are the other forms of immunotherapy for allergic rhinitis?
Other forms of
Immunotherapy.
sir, the sublingual immunotherapy, it can be a subcutaneous immunotherapy, but according to guidelines we have seen, like the statistics says that there are more allergic reactions seen in case of skit rather than slit.
Besides immunotherapy, what is the other treatment for allergic rhinitis?
See, the medical therapy which can we give is any antihistaminics, like the first generation or the second generation are most commonly given, like levocetirizine, cetirizine, fexofenadine or belastin, and any steroidal nasal sprays like fluticasone furoate nasal sprays. And even when we are giving the slit, we have to give the medical therapy, because these improvement in symptoms is not seen on the first day only. So we have to give a support, medical support, like medical therapy is advised when there is initiation of the slit.
Okay. Okay.
In a particular patient, just tell me when to start immunotherapy. At the first visit,
Sir, if the patient with first comes to a clinic with complaints of sneezing,
you have diagnosed it as a case of allergic rhinitis. Then
and
what
then
will be the treatment?
First, we'll give the medical therapy for at least 6 weeks, and then we'll look whether there is any improvement in the symptoms. If there is no improvement in the symptoms, then we'll ask the patient to go for the skin prick test to identify the specific allergens against which the patient is allergic.
Then what will be your advice after that?
Then we'll
After performing the skin prick test,
then the patient for the treatment of allergic rhinitis, there are 4 corners. First, we have to tell the patient to avoid the allergens to which they are allergic, and then we have to educate the patient according to the lifestyle. Like if the patient is not opening the windows, there is no exchange of the allergens, so there is accumulation of allergen. He is not taking baths regularly or not changing the bed sheets. And then we have to advise the medical therapy, and then the last is immunotherapy, because it is a curative treatment.
okay, just one or two more questions. Just minimum time period for this immunotherapy to be effective.
So the immunotherapy that we give is the for 6 months. It is the primary kit. Like for the minimum is 6 months. We give the
After that, we can observe definite
yes,
relief
sir.
or the symptomatic relief.
Yes, sir.
The next question is automatically comes. Does the snot score have any effect during different seasons in a year?
The SNOT 20 score. Yes, sir. If mostly
Snot score,
SNOT
you are
20
counting
score.
it
Sir,
to
the-
evaluate the efficacy of your vaccination. So you are counting it at different periods of a year. Maybe in the winter, maybe in the rainy season, maybe in the summer, maybe in the spring. Does these seasons have any impact on this snot score?
Sir, if the patient, during some seasonal changes, the symptoms are more, and then we can give false
Then
results.
you have to avoid or exclude these errors.
Yes, yes.
These are
That's why,
systemic errors.
Not the seasonal allergic rhinitis, but the perennial patients who are having persistent allergic rhinitis, they are given the immunotherapy.
Okay.
Thank you, Srijita. Indranil sir, a question আছে?
You are commenting on the efficacy of a particular treatment. Okay, slate. Where is your control group? Yes, without a control group, how can you comment about the efficacy of a particular method? It's okay. SNOT 22 is only the parameter to judge. But where is the control group? Okay, but you have given only a selected group of patients. You did not give any other control group to give parallel, say, placebo therapy. You should have tested SNOT for both of them. But your comment contains there is efficacy. Your comments are lined on efficacy. Then it should have a control group, isn't it? Ideally, because otherwise your experiment, the methodology and your conclusion, they are wide apart. The method which you are following, it should have been a randomized control trial without being an observational study. Number one. Number two, there should have been a control group where you should have given a placebo therapy. And then you can take SNOT for both of them and then ultimately you can conclude, isn't it? Okay. Anything, any efficacy assessment is always with control. Okay.
Okay, I request Dr. S.N. Bandyopadhyay sir to come and hand over the certificate to Srijita. Srijita, please. So, our today's program is sponsored. Actually, today's program is sponsored by CIPLA. They have launched their new product, intranasal corticosteroid combination, Duonase F, which contains, Duonase is a very old brand, and Duonase F contains fluticasone 4-8. So they are with us supporting AOIWB West Bengal in this all academic programs. So, হয়েছে ছবি তোলা? না একদম এতে যাই। হ্যাঁ, there are lots of topics coming ahead, so we cannot waste our time with all the next speaker is Dr. Rupal Ghosh. His topic is lymphoma of paranasal sinuses, a surprising diagnosis.
A very good afternoon to everybody present over here. Today, I, Dr. Rupal Ghosh, presenting a case on lymphoma of paranasal sinuses. Nasal masses are common findings in our ENT OPD. They may be congenital, inflammatory, or neoplastic in nature. And most common patients present to us with nasal obstruction. And sometimes the diverse pathological entities of sinonasal tract lesions with similar clinical findings poses challenge in diagnosing and as well as management of the cases. So a patient, 48-year-old male Hindu coming from Taltala, he presented with us recurrent episodes of nasal bleeding for 3 months, which was spontaneous in onset and self-limiting, scanty in amount, and doesn't need any medications. Then followed by he also developed nasal obstruction, that's for 2 months, for which it was gradual in onset and progressive in nature. And without any, he said that he have taken nasal sprays without any consultancy. He also have a pain below his left lower eyelid region, that is malar region, for 2 weeks. Without any painkiller, he came and no relief of any medications. No negative histories present in this patient of excessive sneezing, recurrent cold, double vision, blurring of vision, watering from the eyes, ringing sensation in the ear, pain or discharge from the ear, any history of trauma is not there. No prolonged medications and headache and no loosening of tooth is present. Then on examination, we did anterior rhinoscopy. In that we found gross DNS towards the right and the pinkish fleshy mass, irregular shape, which was obscuring the left nostril with mucopus, and in right side inferior turbinate hypertrophy is present. On posterior rhinoscopy there is no SOL in the nasopharynx, and on probing we found that the mass is firm, tender, and bleeds on touch. Probe can't be insinuated 360 degree all around the mass. On examination of face, oral cavity, eyes, ear, cranial nerves and neck, we found that no deformity noted over external nasal pyramids, nasophaseal groove, nasolabial groove, no facial swelling, no loosening, no trismus seen, and low lymph nodes palpable over axilla, and neck nodes and groin. Eyes, the extraocular muscles movement were normal, ears within normal limit, all cranial nerves are examined and all are within normal limit. To corroborate our anterior rhinoscopy and the posterior rhinoscopy finding, we did the DNE, diagnostic nasal endoscopy, and we can see this a pinkish fleshy mass covering with mucopus coming from the middle meatal area into the inferior meatus and also pushing the septum towards the right side. On right cavity, ITH is seen, no septal erosion in the opposite side. And choana is completely free from any kind of SOL. We further did the imaging of CECT, nose and PNS. In this, we can see the homogeneous non-enhancing mass involving the nasal cavity, maxillary sinus, and ethmoids. And it's also encroaching toward the breaching the orbital floor. But we exactly don't know that is it involving the muscles of the orbit or not. For that, we did a MRI, CE MRI, to see that in homogeneous hypointense lesion of T2 weighted. In that, we can see maxillary sinus involving an ethmoid, but not involving the inferior rectus muscle, and also no involvement of the mass in pterygopalatine fossa in an infratemporal fossa. But it is involving the periorbita of the left orbit. And after that, we decided to take a biopsy from the mass, and we admitted the patient by doing all the routine examination as per our protocol of the institution, and patient was fit. In that, we found that biopsy report as inflammatory lesion with dysplastic changes. So we again reviewed the slides to the pathology, but the result was again same. So we performed an endoscopic medial maxillectomy under general anesthesia, and we can see the post-op finding of this after pack removal of the cavity. And the patient also had a hemorrhage, secondary hemorrhage after 5 days of pack removal, which was again repacking done, and on medications it was controlled. After that, we sent the sample toward for HP, and the report came as non-Hodgkin's lymphoma of high grade. So immunohistochemistry was suggested, and we again sent the sample for immunohistochemistry, and it came as a lymphoma of diffuse large B cell with high CD20 immunoreactivity. So we referred the patient to radiotherapy and hematology department for further management after staging the non-Hodgkin's lymphoma of DLBCL. Then patient is on now chemotherapy and periodic follow-up. After 2 months, we repeated a CT scan, and here we can see the maxillectomy cavity is wide open, no mass or anything can be seen, no residual or recurrent mass, and choana is clear. Patient is on now periodic follow-up. Lymphoma, it's a malignant tumor of lymphoreticular tissue, resulting in proliferation of lymphocytes. There is 2 types, Hodgkin's and non-Hodgkin's type. In that, non-Hodgkin's lymphoma is more common, that is 62% of all lymphoid malignancies. And extranodal sinonasal tract lymphoma is 3 to 5% of all malignancies. In lymphoma, there is B cell, T cell, and T/NK cell present. B cell is the most common, that is 90%. As in our case also, it is came as a B cell. In sites involving the sinuses, maxillary is more common than ethmoid, then sphenoid, and frontal sinuses. Etiology is varies, hereditary, infections, and environmental factor. In hereditary, there is family history or genetics like associated with Klinefelter syndrome, Bloom syndrome, or Down syndrome. In infections, there is attached with the HTLV1 virus, HTLV2 virus, HIV, hepatitis C virus, HHV8, Helicobacter pylori, and Epstein-Barr viruses. Environmental factor, there is radiations to X-rays or CT scans, like, and chemical exposure to smoking, tobacco chewing, or workers working in any pesticide company, so, benzene, alcohol, like that. And in environmental factor, also a drug phenytoin, it can also cause lymphoma. And treatment for this non-Hodgkin's lymphoma is radiation and adjuvant chemotherapy, and followed by immunotherapy if needed of high reactivity. And 5-year survival rate of non-Hodgkin's lymphoma depends upon the subtype and staging of the disease. Thank you.
Thank you, Dr. Ghosh. It was a B cell type of your lymphoma. What are the other cells? T cells.
B cell, D cell, and T/NK cell, natural killer.
Prognostically, which is better?
B cell is better.
Why? Why T cells are bad or NK cells are bad? Prognostically.
Sir, B cell, their symptoms is they appear more fast, appear slowly, and they are means they on chemotherapy or radiotherapy they react, and the patient develops good compared to T cell and other NK cell.
You have gone to the radiation department with the patient. Have you gone?
No, sir.
No, you just send it in the radiotherapy.
Sir.
What was the dose of radiation for
Sir?
that patient?
What
was the dose of radiation? There is a unit. I mean, they will give not like 1,000 rad like that.
45 to 52 C guy of EBRT.
45 to?
But this patient didn't got any radiations.
How is it cured? He didn't get radiotherapy?
No, sir. But because as per the radiotherapy department, they only started the R-CHOP regimen for this.
Oh. He didn't receive chemotherapy also?
Sir?
No chemotherapy also?
Chemotherapy?
Yeah. What are the chemotherapy agents?
Sir, in this case,
you told about adjuvant chemotherapy. What are the agents actually?
Sir, rituximab, cyclophosphamide, adriamycin, vincristine, and prednisone.
These are alkalating agent.
Sir?
Alkalating agent. These. There are
Alkaline.
some newer chemotherapy drug now.
Sir, near one more is there. MOPP regimen is also there. That is new in lymphoma.
Okay, just steroid, methotrexate, L-aspergillase, ifosfamide. There is a word SMILE, S-M-I-L-E. Okay, just go through.
It's a very nice presentation. The one question first is that it was not confirmed diagnosis before operations. So why not opted for a second time revision biopsy when the first report came as inflammation with dysplasia? This may be the wrong in the part of the surgeon taking biopsy. So without confirmation diagnosis, how will you choose that endoscopic medial maxillotomy will be a sufficient operative case in this case? Because there is already involvement also. So why you have not choose for the re-biopsy, and why you do the surgical, how you will take the decision of surgery?
Sir, first time we took the biopsy, it was deeper enough. But then also the report came as inflammatory dysplastic changes. So we decided that if we again do the same procedure, it may not come. So for taking much more tissue, so we...
No, it is not the usual scenes. Usually when the biopsies came as insufficient or inflammatory, it is the fault of the surgeons taking the biopsy. If you take a re-biopsy, usually the positive report comes by second surgery.
And
So you have to take a diagnosis before doing some surgery. So why you have choice for the endoscopic medial maxillotomy?
Sir,
What is the rationale for this type of approach? What is the provisional diagnosis from clinical findings and from radiological findings?
Sinonasal mass of malignant etiology we suspected.
So malignant etiology.
Yes, sir.
So why you will not a total maxillectomy like that when there is orbital involvement?
Sir, as per discussion with the anesthesia, they also told that this...
No, this is anesthesia will not take the decisions. Anesthesia will need the surgical decisions. It will be the surgeon's decisions. So when there is orbital involvement and the mass is going to the orbit, so you prefer to use a total maxillectomy. So why you do the endoscopic medial maxillectomy? This is not a treatment for the CA maxilla with involvement of the orbit. Okay.
Did you do a punch biopsy? Once?
No,
The
no,
lux-
sir.
Only once? You've taken biopsy in the first sitting, only from one site or different sites?
From multiple sites in during the GA anesthesia only. No punch
All,
biopsy.
all came negative for lymphoma?
Yes,
all
sir.
came strange. Okay.
Okay.
No more question actually. When the biopsies are negative, while negative rather, was there any option for to go for immunohistochemistry before the surgery with those samples
Sir,
to get some better picture? That is not possible.
No, sir. Without any confirmation of any malignancy, we
You
can't do
cannot go,
immunohistochemistry.
and without these things, you have opted for this somehow semi-radical surgery actually. What was the fate of nasolacrimal duct in your case?
We sacrificed the nasolacrimal duct in that side.
You went for a rather little bit aggressive surgery. Yeah, okay.
Have you gone through the literature or not before preparing this article? So there is no publication you have seen that this lipoma of the paranasal sinuses are very common, or lymphoma, yes. No, my question is, what is your name of the article? You have written that lymphoma of the paranasal sinuses. You have got only one case. That was in the maxillary antrum involving the orbit. So in that case, how can you say that broadly the lymphoma of paranasal sinuses can occur in other sinuses also? Why not in other sinuses? Or that you have got from the literature only you can avail this information. Otherwise, how can you? If you don't go there, then you should change your name of the article. You should say that it is a surprising case of lymphoma of the maxillary sinus, a case report. That much you can say, not more than that. You must have a thorough literature searching, and you will have to give references of all this, isn't it? How have you taken the biopsy from the antrum? It is antral growth, isn't it? How have you taken the biopsy? How have you taken the biopsy from the antral mass? That is my question. Very basic question. That may not be a representative one. You have taken from inside the maxillary antrum. That's all. Thank you.
Thank you, sir. I request Dr. B.K. Roy Chaudhary sir to hand over the certificate to Dr. Rupal Ghosh. Actually, sir has asked to read more and more before presenting. So our next speaker is Dr. Rupsha Saha, an enigmatic presentation of cervicofacial tenomycosis.
Very good afternoon to all the delegates present in the hall. I am Dr. Rupsha Shah, and today I'd like to talk about an enigmatic presentation of cervicofacial actinomycosis. To begin with, I would like to give a brief introduction. Actinomycosis, as we all know, is a rare chronic disease caused by Actinomyces species. They are filamentous, gram-positive bacilli, mainly belonging to human commensal flora of oropharynx, GI tract, and urogenital tract. Clinical features of actinomycosis may be manifested at various anatomical sites, starting from face, bone and joints, respiratory tract, GI tract, genitourinary tract, CNS, skin, soft tissue, and where not. In any site, actinomycosis frequently mimics malignancy, tuberculosis, or nocardiosis, as it spreads continuously and progressively and often forms a cold abscess. Actinomycosis in the maxilla accounts for only 0.5 to 9% of all head neck cases. However, cervicofacial actinomycosis itself is not very uncommon. It accounts for about 50% of all the actinomycosis cases. Cervicofacial actinomycosis is characterized in the initial stages by soft tissue swelling of the perimandibular area. Direct spread into the adjacent tissues occurs over time along with development of sinus tracts that discharge yellow purulent material. Invasion of cranium or bloodstream may occur in very rare instances if the patients or the cases are left untreated. In my case, a 59-year-old male presented in our outpatient department with gradually progressing ulcer over infraorbital and maxillary area, with discharge and occasional yellowish crust developing over a period of 1 year. The patient also complained of difficulty in chewing and trismus for a period of about 6 months. This is the picture of the patient on presentation. Examination showed multiple discharging sinuses, yellowish discharge, occasional crusting in the deep-seated ulceroproliferative base over the affected area, as mentioned earlier. Left-sided level 2A cervical lymph nodes were palpable. No other significant lymph node enlargement was noted. Now, may I come to the investigations? Gram staining of the tissue collected from the ulcerated area was performed, and it suggested growth of gram-positive filamentous organisms with presence of sulfur granules. Culture suggested that the organism is actinomycete. Sensitivity report showed the organism to be sensitive to doxycycline while being resistant to all the possible other empirical drugs. This is the gram stain of actinomycetes showing gram-positive filamentous non-acid-fast bacteria. A complete blood count of the patient was also done, and the picture showed leukocytosis with elevated neutrophil count. Now, CT scan in this case was not a diagnostic investigation. However, we performed it to see and to rule out any kind of bony invasion or any soft tissue, adjacent soft tissue erosion. 45 into 34 millimeter lobulated irregular soft tissue lesion in left lateral nasal wall was noted, causing erosion of left half of body of maxilla and inferior wall of left maxillary sinus. Moderate mucosal thickening in bilateral maxillary sinus and deviated nasal septum towards left with bony spur was also noted. As for the culture report, the culture report showed growth of actinomycetes, which in turn was sensitive to doxycycline as per the sensitivity report. A course of doxycycline was started and the patient was followed up every 15 days. As the patient showed improvement, doxycycline, the course was prolonged for a total period of 6 months. However, after the therapy also, on follow-up visits, the discharging sinuses and the swelling, though reduced significantly, however, ulceration persisted. Punch biopsy was taken from the lesion because of the doubts, and HPE report was suggestive of moderately differentiated squamous cell carcinoma, after which the patient was referred to radiotherapy department for further management. To conclude, I would like to say that actinomycosis is a rare chronic disease caused by actinomyces species. Streptococcus pneumoniae, Haemophilus influenzae, and Staph aureus are more frequently identified organisms noted in immunocompromised patients. Again, cervicofacial actinomycosis may be confused with squamous cell carcinoma, basal cell carcinoma, scrofuloderma, nocardiosis, etc. So this was a case of superinfection of actinomycosis in a case of cutaneous squamous cell carcinoma, which itself is an enigmatic and scarce entity. The main modality of treatment for actinomycosis is conservative with injectable antibiotics. Surgery can be adjunctive. These are few of my references. Thank you for your patient listening.
Thank you, Dr. Shah. Was the patient immunocompetent or immunocompromised?
So initially, as we took the history, he did not present with any such history of immunocompromised state like diabetes or any previous history of carcinoma or tuberculosis or anything. So initially we considered him as immunocompetent only. As we progressed with our diagnosis, we found out that he was not actually immunocompetent. He was suffering from squamous cell carcinoma.
So it was an immunocompromised patient.
Yes, he was immunocompetent.
In any slide, you didn't find any squamous cell carcinoma beforehand?
No, sir. Actually, the lesion was localized. There was no other swelling or any soft tissue lesion anywhere else, noted anywhere. So we were focused on controlling the swelling and the discharge from that local area only, the maxillary area, the left-sided maxillary area was involved. So initially, after we reduced the swelling, we took scrape biopsy from the region.
Then
So
it came as
that came as actinomycosis only. We did not find any kind of malignant tissue on HP. So after the swelling reduced and the discharge subsided, the ulceration was not subsiding. The other features of inflammation subsided, but the swelling the ulceration did not go. So that's why we plan to take a repeat biopsy.
So, just considering this patient, don't you think that we all have wasted 6 months to 1 year for the patient who was having a squamous cell carcinoma at the same time? I mean, a double pathology.
Actually,
It's quite a tricky situation. It's not a normal situation.
Yes, sir. It's not a normal situation. I think as we could not diagnose it properly at first, we concluded the diagnosis to be actinomycosis only. And the patient was resistant to all other common empirical antibiotics. That's why we started with doxycycline. And as the patient showed so much benefits, we decided on continuing the treatment.
Now, in the facial region,
Yes.
which carcinoma is more common? Is it squamous cell carcinoma? I mean, in the outer part, in the face.
Yes, the squamous cell, it can be basal cell carcinoma also, squamous cell, basal cell carcinoma.
Actinomycosis is a common disease in previous years, in yesteryears. Now, this is not a common disease to find us. Actually, this is very rare to find for ENT surgeons to find. Can you tell me why the incidence has been subsided so much?
Sir, can you please repeat the question? Why?
The incidence of actinomycosis has been reduced, come down very much. What is the cause behind these reasons?
So maybe it can be because of the large scale use of antibiotics and
Second question,
Yes,
what
sir.
are the common antibiotics that can be effective against actinomycosis?
So the first line penicillin G, intravenous penicillin G is given. Other than that, before doxycycline, there could be many others like amoxicillin, long-term amoxicillin with clavulanic acid combination.
Penicillin or its derivative, and any other?
Cephalosporins.
What is the main things?
Yes,
What
sir.
is the main diagnostic points of actinomycosis besides histopathology?
Besides histopathology? So we mainly look for the soft tissue swelling with
Especially one type of granular
sulfur granules, sir.
Sulfur
Sulfur
granules,
granules.
That
I
is
mentioned
one
it, sir.
important thing for diagnosis.
Yes, sir.
Okay.
Just one question actually. Actinomycosis are normal resident of our body in different parts of our body.
It
Isn't
commences,
it?
sir.
Natural pathogen. Then why we do get infected with actinomycosis?
So it is mostly seen in immunocompromised patients only.
Not always, not always. Basic thing is somewhere something else. Most of the patient may not be immunocompromised. It is like cholesteatoma. In cholesteatoma, what we say skin in a wrong place. Here also, actinomycosis in a wrong place. Actually, oral cavity has a different actinomycosis species. Over the skin, we have a different species of actinomycosis. In urogenital tract, we have a different species of
Yes, sir.
actinomycosis. When these things get translocated or entered into a different place, they cause these things. That is actinomycosis in a wrong place. Even if it is a normal flora of our body, can produce some signs and symptoms, especially with the production of sulfur granules.
Yes.
Then what is sulfur granule?
It is basically a misnomer, sir. It is the conglomeration or the clumping of the filaments of the bacteria along with the macrophages that form yellowish discharge. The color of the granules has led to it.
Why the granules are yellow in color? Not bluish or golden yellow. Actually, actinomycosis bacteria has some granules, as you have said.
Yes, sir.
Those are yellow in color because of presence of sulfur within those granules. When those bacteria gets fragmented
Yes,
along with inflammatory cells,
it
they
gives
cause
that
this yellowish
yellowish
spots.
color. Yes.
Yeah. Okay.
Thank you, sir.
Any comment from the audience?
Yes, sir. It can be rhinoscleroma, rhinosporidiosis. It's not a, it's mainly inside the mucous membrane.
Many antibiotics, as you said, starting from penicillin to tetracycline, doxycycline, like that. So how long you will have to treat a case of actinomycosis to cure? Have you got any idea?
I request Dr. Amitabh Raychaudhuri, our president-elect, to hand over the certificate to Dr. Rupsa Saha. Our next speaker is Dr. Porichaya Panda, an unusual case of tuberculosis of mandible.
All the honorable members of the jury, my colleagues, my seniors, my faculties, and chairpersons present here, good afternoon. I am Dr. Porichaya Panda, and I am going to present today a case of unusual tuberculosis, osteomyelitis of the mandible. Tuberculosis is a chronic inflammatous granulomatous disorder that is caused by Mycobacterium tuberculosis mostly and some other species which make up the Mycobacterium complex. It is a global burden. In 2021 alone, an estimated 10.6 million people fell ill with TB worldwide. TB is a disease that has crossed all borders and affected all age groups. It is the 13th leading cause of death, and it is the second leading infectious killer after COVID-19. Unfortunately, in our country, it is widely rampant. Pool TB prevalence for India is 41%, and India's TB incidence for the year 2021 was 210 per 100,000 population. In 2018, an estimated 480,000 deaths occurred from TB in India. When we come to TB, there are both forms of TB, pulmonary TB and extrapulmonary TB. The extrapulmonary TB is also quite common, and in the estimated incidence of TB of 2.1 million cases in 2013, 16% were extrapulmonary. Now we come to our case. This was a 7-year-old girl who presented on 2nd January 2023 in outpatient clinic with a 2-year history of enlarging lower jaw swelling. It was gradually progressive in nature. There was no past history of hemoptysis or chronic cough. There was a past history of night sweats and low fever, which were 2 years back and which subsided on taking medications. On clinical examination, the swelling over the left side of the mandible was approximately 4 by 3 centimeter in size. It was globular in nature. There was no discharging sinus or fistula over the skin over the swelling. On palpating the swelling, we found that it was non-tender, it was woody hard, the margin was well marginated, the surface was smooth, and the skin over the swelling was mobile. That is, we could pinch off the skin over the swelling. On intraoral examination, we could see a swelling in the molar region. The gum was swollen over there, and we could see dental caries over there. On this presentation and this history taking and this clinical examination, we arrived at the diagnosis, differential diagnosis of Garage osteomyelitis or a fibroosseous lesion. Garage osteomyelitis is basically a chronic non-suppurative bone lesion, and it was described by Garage in 1893, and which later came on to be known as Garage osteomyelitis. We first ordered a few blood picture as a basic investigation, and it showed no significant infectious occurrence except the ESR was marginally raised. Then we ordered an orthopantomogram, and on the left side of the mandible, on the left side of the mandible, we can see there is no lucency, no moth-eaten appearance. There was no positive findings that we could get from the orthopantomogram. We ordered a chest X-ray, and the chest X-rays, there were no symptoms. There was no specific signs and symptoms that could be gained from the chest X-ray. Then a CT scan was done, and we found mixed sclerotic and lytic areas seen in left lateral aspect of the body and ramus. Adjacent non-enhancing collection in the intramuscular compartment were seen. These features were likely of osteomyelitis involving mandible with intramuscular abscess formation. Then we went on for an incisional biopsy and histopathology in this patient. So H&E staining of the slides were done, and we saw caseating necrosis, which was suggestive of tuberculosis, and we also saw giant cells. An adjacent enlarged lymph node was also sampled, and it showed signs of reactive hyperplasia. These are the H&E stained slides in 100 times magnified and 200 times magnified. On the 200 times magnified slide, in the lower border and the upper border, we can see the pinkish hazy cells present. These lower slides and the upper sides have no internal cellular organelles. They're all dead. Only the cell membranes are present. So these are the signs and symptoms that are usually seen when a caseating necrosis happens. In the center of the slide, in which the 200 times magnified, some alive tissues are there, and we can see blood vessels present there. We can see blood vessels present there. So, and this is another slide which is 400 times magnified. In this, we can see two giant cells. Giant cells are multinucleated cells that are usually seen in a tissue invaded by tuberculous bacilli. So, final diagnosis, we arrive at tuberculous osteomyelitis of the mandible after histopathological examination. So, the patient was registered under National Tuberculosis Elimination Program, and she was commenced on DOTS therapy, which is HRZD for 2 months of intensive phase and HRE for 4 months of continuation phase. She is now well on follow-up, and at the end of therapy, we plan on reassessing her for surgery if at all necessary. So dissemination of tuberculosis outside lungs can cause skeletal TB. TB osteomyelitis is usually due to hematogenous spread from gut or from the lungs. Reactivation of the bacilli that is lodged in the joint space of any bone occurs after the primary infection, but sometimes you can see that both primary and TB osteomyelitis are present. TB bacilli may travel from lung to the spine along the Batson paravertebral venous plexus. According to the pre-1950 literature, oral TB was 0.1 to 5% of all cases, and mandibular TB among the oral TB was far more rarer. This has decreased. The prevalence of this oral TB has decreased after the pasteurization of milk has begun. Radiology in cases of TB osteomyelitis usually shows lucency and erosion, and the diagnosis has to be reached by doing an histopathological examination after taking a biopsy. The chemotherapeutic regimen for treating an extrapulmonary TB is same as that of treating a pulmonary TB. Minimally destructive lesions may suffice only anti-tubercular drug therapy, but in case of a moderately destructive lesion, anti-tubercular drug therapy along with surgical debridement and reconstruction wherever necessary is required. So on concluding, TB osteomyelitis of the mandible is a very rare phenomena. Imaging may not show expected osteolysis, minimal periosteal reaction or erosions. Like in our case, no imaging showed. Histopathology is usually required for diagnosis, and TB is a great mimic. It should always be kept in mind while observing cases of craniopharyngeal swellings and all. Thank you for your patient hearing.
Thank you, Dr. Panda. It's a nice case. Did you go for serology study?
Yes, sir. At first, we didn't expect this to come out as tuberculosis osteomyelitis, but biopsy was taken and viral serology was done. So she was non-reactive to all of those.
Negative to everything.
Non-reactive.
So what came? It is a primary tuberculosis.
This is a primary tuberculosis,
So
sir.
what may be the actually factors for this primary tuberculosis? What are the factors? Just only mandible is having this type of tuberculosis.
Sir, we can expect any kind of dental infection also.
Where? Which part of the?
Sir, retromolar, we already have a dental caries there, but maybe she have inoculated the tuberculosis bacilli from that route.
Was there any bone grafting done beforehand?
No, sir. Bone grafting was not done. On biopsy, when biopsy was being taken, we observed...
Sorry, sir. You don't get my point. Was there any bone biopsy beforehand, before diagnosis?
No, sir.
Okay. And which part of the mandible gets more infection? Which part of the mandible? Mostly.
In case of tuberculosis osteomyelitis, sir,
Yeah.
ramus. Body and the ramus.
Which part? Ramus or body?
Sir, ramus.
Ramus. Okay. And one thing, you are saying that it is osteomyelitis.
Yes.
What is the confirmatory diagnosis of an osteomyelitic thing? There is a coming out of some dead bones in case of osteomyelitis.
Sir, to diagnose an osteomyelitis, usually mandibles are not involved in osteomyelitis, but in longer bones, we have to see the sequestra formation. But those can only happen in long bones. Mandible doesn't have that kind of a.
So why you are talking about osteomyelitis? Why? There is some point.
Yeah, we are talking about the osteomyelitis because the myelin, that is the middle, was involved, and as well as the osteum, that is the external structure of the mandible, both were involved. This is an inflammation of both the osteon and the myelin of the mandible because of the TB. That's why we convert to osteomyelitis.
It's a very nice presentation. So can you tell me how we can diagnose tuberculosis? Still, it is a difficult thing to diagnose tuberculosis. What are the ways for extrapulmonary?
Sir, extrapulmonary, we can go for a biopsy and we can do gene expert of the tissue obtained, and then we can easily diagnose tuberculosis osteomyelitis from that. Moreover, what we have done is a histopathology examination, and then we can see a caseating necrosis or a TB granuloma, in fact, and a giant cell, which will confirm our diagnosis of tuberculosis.
Is there any role of FNAC?
Yes, sir, there is a. Sir, FNAC is a bit problematic because fistulous tract formation might occur, and that tract might not heal if it is tuberculosis.
FNAC or it is in incisional biopsy?
Sir,
Why the tract formation is more common?
FNAC. FNAC or excisional biopsy, sir?
So what type of biopsy will do? Incisional biopsy or FNAC?
Incisional biopsy in case of tuberculosis.
There is no role of FNAC.
Sir, this I would like to avoid this question. I am not sure about it.
So what are the other ways of diagnosis?
Sir, pulmonary TB we can diagnose by extrapulmonary TB.
Extrapulmonary. Usually we deal with extrapulmonary tuberculosis. As the ENT surgeons, lots of tuberculosis patient comes to us with glandular swellings. Yes. Or any other in the way.
Sir, gene expert, CBNAT, biopsy, tissue biopsy, histopathological examination. These are the methods by which we can. Or we can do Zeil-Linsen staining, and if we can demonstrate an acid-fast bacilli, then that also would suffice. Sir?
Okay, thank you.
RT-PCR.
Nothing to ask. Is there any role of any immunological test to diagnose tuberculosis? I repeat, immunological test. All you have mentioned about biopsy, granulations, caseations, and CBNAT, everything is there. But I mean, PCRs are there. But is there any role of immunological test to diagnose tuberculosis? What are the advocacy of the NTEP to diagnose extrapulmonary tuberculosis?
Sir, in case of extrapulmonary NTEP, this
National
exact
tuberculosis elimination program.
Mhm.
They have certain guidelines actually. So what are those for extrapulmonary tuberculosis? If anyone working in government hospital, there is a format actually. Tissue sampling. Okay.
Thank you, Porichai. Audience want to comment on anything? I would like to.
Skin prick test, Montooks can be done, and based on diameter. That is not confirmatory, but that is also done. For some Montooks test, that is not confirmatory, but that is skin prick test.
Test is advocated in NTEP.
No, sir. For extrapulmonary TB.
I am talking about NTEP. There is a fixed guideline actually.
So.
So please. Yeah.
Most. Yes.
Or even when we are traveling in a bus or train, automatically we are getting some infection from other people actually. So maybe we have improvised that from 5 tuberculin unit concentration to we have from 10 to we have diluted it more to 5 to get more sensitivity, specificity. But even if that is not working.
So I would like to request Indudin sir to please come on the dais to hand over the certificate to Porichai. So next speaker is Dr. Tapojit Dash. His topic is reconstruction of the saddle nose deformity after septal abscess.
Good afternoon, sir. I am going to present my topic, that is reconstruction of saddle nose deformity after septal abscess. My patient name was Azim Sheikh. He is 19 years old male, tailored by occupation, resides in Murshidabad, Shagordikhi, presented in OPD for the nasal obstruction since last 5 years and the flat nose, which results the distorted appearance of his face. In further probing, we come to know that there is a history of trauma since last 5 years. After that, he gradually develops nasal obstruction and the pain over the nose. Then he sought to medical advice, and the clinician told her that there is a buildup of pus inside his nose, and he underwent drainage of pus. Few months later, his nose gradually becomes flat and he develops nasal obstruction. There is no history of chronic nasal discharge, bleeding from nose, reduction in smell, and the history of leprosy, tuberculosis, and the syphilis. Only one time there is a history of incision and drainage of the nasal septum at the 14 years of age. He belongs to the lower caste family with a monthly income of 8,000. In general survey, patient is conscious, alert, cooperative. His nutrition build is average. His facies is normal, except this is grade 4 saddle nose deformity. He is Ricovirus of choice, vitals are stable, no pallor-icterus clubbing cyanosis that is found. On systemic examination, everything is found to be normal. On local examination of the nose, there is no visible scar swelling, and by inspection, there is a gross saddling of nose. On palpation, caudal test found to be bilaterally positive. That indicates there is a deficiency of the internal nasal valve. In anterior rhinoscopy, posterior rhinoscopy, and diagnostic nasal endoscopy, all structure found to be normal. On the ear and the oropharynx of the oral cavity, everything is normal. Now comes to the photographic assessment. This is the frontal view. We can show that the upper 1/3 of the nose, that is nothing significant, but the middle 1/3 of the nose, it is wide and the inverted V-shaped deformity. And the lower 1/3 of the nose is also broad. Broad means if we draw a perpendicular line along the medial canthus, the lower portion of the nose exceeds the perpendicular line. And in the basal view, what we see, that is the triangularity of nose. That is normally should be triangular, but here is the trapezoid. Tip is slightly broad, base is also wide. Columella is to lobule ratio is 1:2. This should be normal 2:1, but the nostril is symmetrical. In the lateral view, we can comment on the nasofrontal angle. This is deep. Normally, it should be 130 to 115 to 140 degree. The nasal starting point is very low, and the dorsum is concave. The nasal length is short, and the tip projection is decreased. And the nasolabial angle, that is almost acceptable margin, that is, and the columnar show is retracted. And this is the lateral view upright. We can see the same things. This is the oblique view. This is not mandatory for the septorinoplasty or something else, but the oblique view is important in that respect. When we see the patient, see the nose, we see in the oblique view. This is the subjective assessment of nasal symptom preoperatively by using the nasal obstruction and septoplasty effectiveness scale. We see here here we measure it is a 17 point. And the hair management, we do what is the photo documentation, counseling, physical examination, routine investigation, surgery. Photo documentation, as we have been discussed earlier. In the counseling portion, this is very important part. All the things we have to discuss with the patient regarding the knowledge of the patient, details about the which surgery to be done, and the complication, need for follow-up, and the requirement of the revision rhinoplasty. What we could do in this surgery, we went for the open approach septoplasty, giving the transcolumnar and the marginal incision. We harvest rectal fascia graft along with 7-8 costal cartilage to augment the depressed area. We use septal spreader graft, and we take 2 centimeter by 2 millimeter costal cartilage, which fixed to periosteum of the anterior nasal spine, stitched to it 40 polyraxon. And the bilateral extended spreader graft is used, thus forming a new L strut, which gives the support to the main area where tip doesn't fall, and the septal extension graft is also used. Osteotomies is done bilateral, paramedian, and lateral. Tip work, we see that tip projection is decreased, so we increase the tip projection, and modified tongue in group is used. Sutures, we create the domal creation sutures and the interdomal suture, and the shield graft is also used to give the contour of the nose. Augmentation, in augmentation we use the cartilage wrapped in the rectus fascia, and the incision closure was normal. Post-operatively, we removed the plaque after 7 days, plaster of Paris cast was removed after 10 days, stay suture after 10 days, antibiotic given for 14 days, and the nasal irrigation continued for few months. We have to ask the patient to follow up at the first follow-up at the 10 days, second at the 3rd week, third at the 6 months, and fourth follow-up at the 1 year. Then we have to ask the patient to follow up regularly. And this is the post-op image after 3 weeks. We can see that the depressed area has been elevated, tip has been augmented, and this is the basal view. We can see that tip has been increased, but there is slightly irregularity in the nostril. Hope with that will become triangular as the time progresses. This is the post-op image after 3 weeks in the lateral view. And this is the post-operatively nose scale. Here we can see the significant improvement in the patient's sign and symptom. Thank you.
Any other method of surgery apart from this cartilage, costal cartilage? A very simple procedure sometimes followed in case of your saddle nose.
What's that?
In case of this type of saddle nose, you can do another type of surgery, taking some other type of grafts.
Achha, we can use the temporal fascia graft, and we also has a conchal cartilage.
Have you ever heard of the name of dermofat grafts?
What's that?
Dermofat grafts. Dermofat. Fat from gluteal region like that. You can do in local anesthesia also. It takes very short time. Okay. Now one thing. Have you just asked the patient about the rhinoplasty outcome evaluation test, the questionnaires?
What's that?
Rhinoplasty outcome evaluation questionnaire.
No, I don't ask. I have observed the patient for the nasal discharge. That's why we have evaluated the preoperative nose scale and the postoperative nose scale. And the main complaint of the patient is the nasal obstruction. And along with that, there is a depression of the nose. As the patient is 19 years of old and the patient wants that something better to be done with his nose. That's why we went for the
All
septorhinoplasty.
type of rhinoplasty, the patient should be gone through rhinoplasty outcome evaluation. Okay. There are some set of questions there. Okay.
It's a nice presentations, but one thing, why you are thinking that this is due to septal abscess? How you know that this is from septal abscess?
Because sir, there is a history of trauma. After that trauma, patient
Septal abscess, what the deformities developed?
What?
After septal abscess, in which portion of the nose the deformity is developed?
This is the cartilaginous portion of.
But in your case, if you see the picture, the cartilage is looking normal. It is the bony portion which is much more depressed.
No sir, no sir. In this patient, there is septal cartilage is totally absent. That's why you have to reconstruct the septal cartilage. Normally, during augmentation, we can also use the septal cartilage.
From your picture, this is happening. Have you done the CT scan? Why you have not done CT scan for assessment, proper assessment? Have you required to do a CT scan before rhinoplasty?
This is not required in every case, but here we.
Then in which case you will advise CT scan?
There is a case of binder symptom that is completely sinomaxillar aplasia. In that case, we can do CT scan.
Nowadays, even you are doing CT scan in case of DNS. Before doing septoplasty or SMR operations, we are doing CT scan to exclude any pathology in the sinuses. So before doing, I think it is a very rare question that you should do a CT scan before. Yes.
Why the cartilage is necrosed in septal abscess? From your slide, it doesn't seem that this patient was having septal abscess beforehand, because the cartilaginous framework is all right. Okay. Did you inquire for any trauma?
Yes, sir. This is past history of trauma.
So that is the point.
Yes,
okay.
Sir.
Most likely, I'm not sure, this patient was not having an septal abscess, because abscess just have an injurious effect to the cartilage. Cartilage will be destroyed. Why cartilage will be destroyed in case of septal abscess? Why? Why do we drain the abscess? We have to drain the abscess.
Yes, sir.
And instantly. If there is abscess formation, we have to drain it instantly.
It is very simple. Why there is necrosis of cartilage after septal abscess? Why there is necrosis of the cartilage after septal abscess?
Modified tongue in group. What is modified tongue in group?
Modified tongue and group in the we can in between the septal medial two portion of lateral crura you use the septal graft. Septal spreader graft is even in portion between the medial crura.
It is tongue in group. Where is the modification? It is tongue in group, suturing the medial crush of the both lower lateral cartilage with the septum is tongue in groove. And what is the modification? I will just go for the literature. Then how you could arrive at a diagnosis that bilateral Cottle test positive? Bilateral. What is the basis of Cottle's test?
We pull the chin upward and laterally, and ask the patients to breathe slowly. If the breathing improves, then there is a disparity in the internal nasal valve area, vestibule of the internal nasal valve area.
Thank you, Tapojit. I would like to request Dr. Subrata Mukherjee sir to please come on the stage and give the certificate to Tapojit.
So at the end of the program, I thank CIPLA for supporting us I request Sovik from Sipla to say a few words.
Thank you very much, first of all, for letting me speak in this stage. First of all, I would like to thank the association for, on behalf of SIPLA, to let us participate in this beautiful program and help to progress the subject further. And SIPLA is always helps in the favor of progressing the science, and it will do so in future with your support. And today our main focus on our brand, that is Duones F. You all know Duones, it is a age-old brand, but right now we are having Duones F with fluticasone furoate and azilastin combination. So we would all like to get your support regarding this brand also, as you have all made Duones very successful. So we would all request to get the same support for Duones F also. With that, I would like to conclude my talk. Thank you very much.
So before Durga Puja, this is our last meet. So wish you all happy Durga Puja. We'll meet again after Durga Puja. The date of Vijaya Sammilani will announce as soon as we fix the venue. And our next clinical meeting is on 9th November, Thursday, at same venue and same place.